Hello, my name is Alani Frederick, and this is my NKU Morbidity and Mortality Weekly Report for DNP 801. So in this report, the population that we're going to be looking at is public health nursing interventions aimed at increasing vaccination rates among children under 18 years of age. So because this is a pediatric population, the majority of these interventions are going to be concentrated towards the caregivers and the medical decision makers of these pediatric populations. So in summary, what is currently known about the topic is that we've had a year-over-year decrease in vaccination rates among incoming kindergartners as reported by the CDC. Also through literature, we're able to identify certain at-risk individuals. So Hill et al. Tells us that we do have some at-risk populations, such as low socioeconomic status, as well as individuals that use public assistance and insurance. What this presentation is going to bring to the topic is prevention strategies to be used by healthcare providers to help increase compliance specifically with the caregivers of these pediatric patients, as well as particular communication strategies which should be utilized to help build a positive provider-patient experience. The implications for overall public health include decreasing communicable disease rates by increasing vaccination, as well as improving overall health by decreasing disease and disability associated with these communicable diseases. So for the literature, there are clear benefits of vaccination. Hill teaches us that there are over 14 different childhood diseases that are preventable by the current CDC-approved vaccination schedule that's administered within the first 2 years of a child's life. A good example provided by the Health and Human Services regarding a positive vaccination campaign would be the polio vaccination campaign. This was begun and conducted in the 20th century with the discovery of the polio vaccine, which helped to minimize rates of polio in the United States and increase health outcomes for those at-risk pediatric populations. So we know that vaccination works, but Cooper teaches us that vaccination only works with high vaccination adherence numbers due to the herd immunity principle. Now, with current vaccine rates, the CDC has recently reported that there has been a decrease year over year from 2019 in overall kindergarten compliance with some main vaccination factors of DTaP, polio, MMR, and varicella. 2019 to 2020's incoming kindergarten class had a compliance rate of 25%, or of 95%, pardon me. It went down to 94% in 2020 to 2021, and now currently in this last 2021 to 2022 year was 93%. The Healthy People 2023 goal for the same set of vaccinations happens to be 95%. Additionally, there's a large spread in adherence to vaccinations depending on where you live in the United States. So, for example, Alaska is the lowest vaccination compliant rate for the MMR, DTaP, polio, and varicella vaccinations. The reason for this tends to do with barriers to access to healthcare because of how geographically dispersed and rural Alaska is compared to other places in the nation. Now, additionally, we have seen changes in national vaccination rates for things such as the rotavirus. The rotavirus, as shown to us in Kemp et al., has an overall compliance rate of 80%, and that decrease is cited as being a result of parental hesitancy due to previous vaccine safety issues. And the influenza vaccine, which was shown by Gates et al., actually wavers as populations get older. And in the 13 to 17-year-old group, vaccination rates and compliance for the annual vaccine for influenza drop to 20%. Now, what we do know about the caregiver role, which is taught to us in Cooper et al., is that there's 3 main components that have to do with a parent's view of vaccines, which is their view of health and illness, so how they view health and illness continuum. Also, their view on things such as culture and society, because we know certain groups have a natural or an understandable fear of the healthcare system due to systemic issues that have happened over the years. And then additionally, trust and distrust in wider political issues influences the caregiver's likelihood of being vaccine compliant. Surveillance and monitoring is done by the CDC, and there's three main ways it's completed by the CDC and or independent investigators. So there is a web-based surveillance system, which is utilized by the CDC in correlation with health departments and departments of education for certain data points. For example, entry vaccination rates for kindergartners. That's how we get this information, is schools and health departments reported to the CDC. Now, the CDC realizes that there might be gaps in the information gathering with that because not everyone goes through a traditional educational experience. So they also conduct an annual telephone survey where they do call and ask ask parents of pediatric patients if there is compliance. Now, additionally, what's done by a lot of independent investigators is for research is they go ahead and pull insurance data. What has been interesting is Gates et al. Teaches us that influenza data tends to be much different than self-reported data. So previously, it was thought that about 56% of students or children were compliant with their annual influenza vaccine, when it turns out when we look at insurance claim data, it's actually much closer to 33% compliance. Now, the concern that we're talking about today was identified through that CDC monitoring, because once again, we've had that drop from 95% in 2019 to 94% in the 2020 academic year to now 93% in the 2021 academic year, which is decreased from the Healthy People 2023 goal of 95%. And we can go ahead and see that reported vaccination rate here. You can see that differences is MMR, Tdap, polio, and varicella. What you also may see is that there are approved or accepted exemptions in the population, but even when you add the exemptions to the rates, there's still a significant portion of the population that is vaccine non-compliant. Here's another illustration of the current influenza vaccination rates across the nation. And you can see that there's a large spread depending on the state on how compliant an individual might be. Now, we do know that there are clearly groups that are at risk. Low socioeconomic status is correlated with low vaccine adherence. People that are in a low socioeconomic status tend to work low wage positions, which means a lot of times they have to work high hours during traditional, service and retail industry hours, which means they may not actually be available to take their dependents to their annual exams, to be able to do those things such as vaccination clinics. Additionally, individuals that rely on public health care who also tend to have low socioeconomic status do also tend to struggle with vaccine adherence. Black and Hispanic groups also struggle. This not only has to do with possibly their low socioeconomic status, but also in addition, and the fact that they tend to live in healthcare deserts where it's difficult and there may not be a good source of public transportation to get them to the appointments. And then additionally, there are societal hesitancies due to the long-standing issues racially and equitably with the healthcare system. And then finally, it is actually shown in Stroop et al. That there is a correspondence and a relationship between individuals that believe in conspiracy theories and a lack of vaccine compliance. This often comes because there is a distrust of any public system, including public health care. So the review of literature tells us that there's clear benefits to vaccines. There are barriers to vaccine administration because, as you saw, even when we add the exemption into the incoming kindergarten numbers, there is a group that is not accounted for, a significant portion of the population. So then we have to do some things to change that. So short-term and long-term impact from improving these health outcomes is going to be in the short term. Well, there obviously is going to be a decrease of communicable diseases. CDC reports that there's over 1,000 cases of measles in 2019 that were contributed to under or unvaccinated individuals. Additionally, children still die every year from pertussis as well as fall ill. Long-term benefits are going to include decreased rates of disability and death due to these communicable diseases. And then also there are educational and economic outcomes that can be associated with long quarantine periods, which we all experience with COVID-19 as a society, that also are in fact available if you are quarantined for, let's say, a measles exposure or a rubella exposure. So the public health response, we should be focused on who needs vaccinations. We need to identify who needs vaccinations through set points such as school entry physicals, sports physicals, yearly visits. Then when we identify who needs a vaccination, we need to make sure we don't rely solely on guardian memory. What we are able to deduce and what Blagden tells us is that guardian memory can be wrong up to 25% of the time. We need to look at the medical record. Then once we identify there's a gap, we need to affirmatively offer vaccination. We have to make sure that the vaccine is available, because if we do have a guardian that is willing to have their dependent get vaccinated, but we do not have the vaccine available, they may not return for it. And then patient reminder and recall systems are automatic systems that notify patients when they become due for, let's say, their next dose of a vaccine. So this can be simple phone calls, text messages, email reminders, but something to get it in the patient's mind that they're coming due for a vaccination. So for prevention strategies, do remember that this population is under 18 years of age. So when we think about strategies, we're really thinking about strategies for their caregivers. So it is true that vaccinations are just purely a form of primary prevention. Secondary prevention for these communicable diseases would include screenings, such as COVID-19 screenings when you go into public places. Tertiary prevention would be the treatment of these communicable diseases. So with COVID-19, antiretrovirals, antipyretics, depending on the different communicable disease, there'd be different types of tertiary prevention. Strategies to lessen healthcare concerns. So communication techniques. Providers need to make sure that they're using open language, open questions, avoiding ultimatums, and avoiding medical jargon, and also being open-minded to evidence being brought by patients. Additionally, we need to make sure that healthcare providers have a good, solid knowledge of the ingredients of vaccinations and utilize the 3C framework, which is confidence of the provider when speaking about vaccinations, understanding that there may be complacency because there is a low perceived risk of vaccinations, and then vaccines have to be convenient. So what is the DNP's role? So when it comes to Essential 1 scientific underpinnings, we need to understand why vaccinations work, how vaccinations work, and how and why vaccinations are safe. Then we need to look at evidence-based practice to really understand what are the best communication techniques and reminder techniques available to help increase safety and belief in safety around vaccines, and to help remind people when vaccines are coming due. When it comes to ethical considerations, DNP prepared nurses need to understand healthcare policy because there are healthcare vaccine mandates. Additionally, we need to understand the ethics correlated with population health, because we need to protect the greatest number of people possible, but balancing it with the right of the individual to liberty and autonomy. And that really can be handled by a properly trained public health individual, such as a DNP nurse, who's able to communicate the need for herd immunity and the need to protect those that cannot protect themselves by increasing vaccine compliance. So the reference list will also be attached, but this was the MMWR for vaccine compliance in patients under 18 years of age with Northern Kentucky University, DNP 801. Thank you.